First patient's a 63-year-old male, status post fall with a bimal equivalent ankle fracture. He underwent right ankle ORIF. Next patient is a 62-year-old female, status post fall with a right non-displaced femoral neck fracture, minimally displaced femoral neck fracture. Underwent a CT scan as part of her workup. And underwent cannulated screw fixation. Next patient is a 76-year-old male, status post fall with a left hip intertrope fracture. Underwent a left hip intramedullary nail. Next patient is a 52-year-old male, status post fall 6 weeks prior with a humeral shaft fracture. The owner left humerus ORAF with bone grafting, 4-5 plate.
Hey, John, why did you decide to fix that one?
So he was at 6 weeks, post fracture. I did not have some of the X-rays available to me, but there was a little bit of callus formation, but the angulation was bad. There was pretty much some gapping at the fracture site, and there was quite a bit of shortening.
You mean angulation is bad? What does that mean?
Yeah, so there was still gross motion at the fracture site, and with humeral shafts, 6 weeks is considered a non-union. With
6 weeks is
So what's
non-union.
acceptable varus valgus angulation for this fracture?
varus valgus angulation is 30 degrees. AP is 20 degrees. 3 centimeters of shortening is acceptable. So he was borderline here. He's still
Doesn't look that short. Obviously, if it's floppy at 6 weeks, that's the indication.
But he was quite floppy.
Do you know what percentage of patients at 6 weeks go on to non-union, and why that's the indication?
Yeah, so with gross motion at the fracture site, no and minimal evidence of callus formation, it's 90%. So it's extremely high. Next patient's an 89-year-old female, status post fall with a left trimal equivalent ankle fracture. It was initially splinted and underwent ankle ORIF. Next patient is a 72-year-old female, super morbidly obese, with a right distal femur fracture. She underwent ORIF with the nail plate combo.
Just super morbidly obese.
It's a BMI over 50. She fit in that category. Next is a
what
was
that?
that?
More body positive.
Sorry. Next patient's a 94-year-old male, status post fall 3 days prior with a left minimally displaced extensor mechanism intact patella fracture. It was made weight bearing and extension in a knee immobilizer.
Right. First patient is a 3-year-old male who fell at home with a right both bone forearm fracture. was minimally angulated. It's closed reduced and placed into a sugar tongue. Is a 15-year-old male who collided with another player during a soccer game and sustained this isolated right middle finger DIP joint dorsal dislocation. He was closed reduced and placed into a dorsal splint. Is a 77-year-old female, status post fall, with a left distal clavicle fracture. She was placed into a sling. Is a 21-year-old male who was a pedestrian struck. For us, had a right humeral shaft fracture, which is closed. However, he had a significant head trauma and remains intubated and with very little neurologic function. He was closed, reduced, and placed into a coaptation and posterior splint. This is a 66-year-old male who fell 5 feet from a ladder and has an isolated sacral fracture on the left. It's made protected weight bearing. This is a 67-year-old female who was a pedestrian struck at low speed with a left pubic rami fractures. It's a 60-year-old male, status post fall with a right calcaneus and talus fracture. CT was obtained to better delineate the fracture pattern. Showing significant widening at the posterior facet and depression. He was initially placed into a bulky splint and then taken in a delayed fashion for calcaneus ORF.
What approach you use?
We used the sinus tarsi approach.
How did you get those posterior screws in there with the sinus tarsi?
A stab wound.
Okay.
This patient is a 48-year-old male who was also in a forklift collision. Who was a non-displaced tibial shaft fracture. He was placed into a long leg cast, made non-weight bearing. Next patient's a 12-year-old female. She had a fall while ice skating. Has a mid-shaft tibia fracture with an ipsilateral fibular fracture. She was placed into a long leg cast. Next patient is a 13-month-old with a distal non-displaced distal tibia fracture. He's placed into a long leg cast. Fell like 2 days ago off the couch. Next patient is a 43-year-old male who was head struck. He has a right femoral shaft fracture, ABC2 pelvis fracture. He's taken the next day for retrograde femoral nail and SI screw right.
What is the treatment for an APC2 typically?
Sorry, treatment for APC2.
Yeah.
Typically, you would also at least stress the front and possibly plate the front.
Well, typically it's you plate the front plus or minus posterior screw fixation. Because that's
So
where the displacement is anteriorly.
He had a associated bladder rupture, which urology repaired. So it was thought that
You didn't mention that.
I forgot to mention that part. So he also has a bladder rupture.
What about an X-fix?
I think that's reasonable. I think probably an exam under anesthesia after posterior fixation would it would be reasonable to treat him definitively an X-fix as well. This patient is a 45-year-old female. She was in a motor vehicle accident. She has non-displaced tibial plateau. She has a hinge knee brace. She's non-weight bearing on that side. She also has a left posterior wall acetabular fracture, which is being treated non-operative. First patient is 93-year-old female, status post fall. It's left femoral neck fracture was displaced. She's medically optimized, taken for left hip reflex. Next patient is a 71-year-old male, status post fall, ground level, presented with this left segmental shaft fracture. Of note, he is a diabetic and takes methotrexate for psoriatic arthritis. He was taken for a supratellar intramedullary. He's currently pending a fragility fracture lab workup. Next patient is a 24-year-old female, status MEC, presented with a left femoral shaft fracture, lateral femoral neck fracture. It was displaced. She CT scans showing displacement of the neck. She was taken for a left hip VHS with a retrograde femur nailing.
So what percentage of patients with femoral shaft fractures energy will have an associated femoral neck fracture?
It's like the
What?
Be 9%.
Nine, yeah. Those are the ones you find. The all comers will have 9%. Then there's missed femoral neck fractures, and that's obviously a much smaller percentage.
Dan, it's a little hard to hear you. I have just a question on that, because it looks like your femoral neck is a little bit displaced. How do you get that to be reduced appropriately before you fix it? What's the technique there?
So what we did was we put her lateral first and see where the neck was in the lateral position. When we did, so it lined up well, so it kind of self-reduced when we put her lateral, which was very fortunate. But if it wasn't, then we would have to open reduce it. So maybe we would dissect over anteriorly into the capsule and then try to palpate and manipulate the lining to get a perfect reduction, the best reduction we can before fixing it.
So the going lateral was your plan for the reduction, or is it just happened to reduce when you were going lateral?
That was our plan for the reduction. Start lateral. She's very morbidly obese as well. So we went lateral to fix the hip, and then we broke down, reprepped, and put a supine to nail the femur.
And is the screw on the DHS through the hole in the nail?
It's not. So we were able to sheet our plate a little bit posterior, and we were able to get one bicortical screw behind the nail, but it's not through the nail.
But you had that screw in before you put the nail up?
Yeah, so we put the most proximal screw in, bicortically to fix our fracture, and then we left the bottom two screws open, and then we were able to shoot the most distal screw bicortically behind the nail. We tried to get a second one in that middle hole bicortically, but it was unicortical.
So there are nails that come with options for lateral, including I don't know if there's this rubber wood, I'm assuming, right?
Yeah, rubber wood.
For example, both the old and new Synthes nails have the lateral options if you wanted to interlock. That's available to you if needed. Not that you necessarily need it, but that's available.
Would you have gone longer with the DHS with that porcelain, or do you think 3 holes?
No, I mean the plank leg is fine. It's holding your femoral neck reduction. Your nail, you overlapping your nail, so that's fine as well.
What's your concern about the placement of the distal of the proximal two locking screws in the nail?
Sorry, was that Dr. Butler?
What am I worried about with your distal of the two proximal locking holes that you used for the nail? where is it? It's distal to the subtroch, and you're in a dangerous position for the femoral artery doing that. You have to be extremely careful
Yeah.
putting that locking screw in.
So what we did was we did a little bit of external rotation of that nail, and we made like a bigger. So we made a bigger incision anteriorly, and then we dissected down carefully to obviously not try to get in the danger zone there.
Yeah,
yeah,
that's the whole point. Just make a
yeah.
bigger incision and do it carefully. This one you can't really do percutaneously like you do the more proximal one.
And no, the key was externally rotating that nail a little bit. If you do the opposite by accident and internally rotate it because you had a difficult nail and a difficult reduction on a 400-pound patient like this, then you're really going through tiger, country. So if you can, externally rotating that nail a little bit can help.
Thanks. Good morning. Patient's 5-year-old male, status post fall, running late at night at home. Present with his left posteromedial extension type 4 supracondylar humerus fracture. He was neurovascularly intact. He had a brachialis pucker sign. He was originally splinted. He was sent over from an outside hospital, and he was taken the first thing the next morning at 6:30 for a left elbow closed reduction to percutaneous pinning. That's all. Thank you.
Morning. The first patient is 20-year-old male, status was MEC with right distal humerus fracture. He was taken to the OR for right humerus open reduction internal fixation. Next patient is 58-year-old male, status was fall with right ankle fracture dislocation. The patient was taken to the OR for ankle open reduction internal fixation. Next patient is 77-year-old male, status was fall with left femoral neck fracture. He was taken to the OR for left hip hemorrhage. That's all. Thank you. That's all cases for today.